Schwannomas of the facial nerve can occur anywhere, but they're usually and most commonly present involving the geniculate. They arise from the outer cell layer and they're slowly progressive. So they may present with slowly progressive facial palsies, but since they're tumors of the covering of the nerve itself may not be damaged until very late. So you may have patients presenting with normal facial nerve function, but who have a facial schwannoma. And remember, facial nerve palsy is almost always not a vestibular schwannoma. Only 5% of patients with facial palsy have tumors. Most of those cases are viral infections, so-called Bell's palsies. Differential considerations: when you see a mass of the facial nerve, hemangiomas may involve the facial nerve, or you may see extrinsic tumors and cholesteatomas involving the facial nerve. This is an example of a facial schwannoma that actually it has a dumbbell pattern that is involving the geniculate, but also is extended through the fallopian segment. So on the MR with contrast, you can see the part of the tumor inside the internal auditory canal, as well as seeing enhancement of the tumor in the geniculate region. This is an example of how CT can be used to diagnose these facial nerve schwannomas. You can see a slightly expanded geniculate. You can see the fallopian canal is too large. It's usually filiform. So the tumor is involving the afferent limb, the ganglion, and a little bit of the efferent limb. This is a case of a patient with a left facial nerve palsy who does not have a tumor. Notice that you can see enhancement on the contrast enhanced study in the geniculate area. That's asymmetric. Enhancement is not always pathologic in this region, but if it's asymmetric and the patient has a facial palsy on the appropriate side of the asymmetry, you're justified in suggesting that it correlates with a Bell's palsy. Remember I talked about, and this is a weird case, so you're not going to see too many of these. In the early days of MR, when we did CT, patients didn't have a scan at the drop of a hat, and the tumors got bigger than they do now because we scan patients more quickly. But this is a patient with an enlarged internal auditory canal, and it's eroded. And you can see a large enhancing mass in the cerebellopontine angle that's extending into the internal auditory canal, pushing the brainstem and the cerebellum away. So if you didn't have this part, you'd think about vestibular schwannoma or maybe meningioma. If you look at the CT, there's gross erosion of the geniculate fossa and erosion of the tympanic facial nerve canal. On the MR, you can see that there's tumor extending into the middle cranial fossa. It's centered in the geniculate region, and there's a large component of the tumor following the anatomy of the tympanic segment of the facial nerve. So this actually had come to us as a meningioma. Meningiomas can grow into the middle fossa, but if they do so through the tentorial incisura, not typically through the petrous bone along the facial nerve. So this is a facial schwannoma, a big one, but it's doing everything a facial schwannoma might do. And facial schwannomas may actually present as masses in the middle fossa because the geniculate does face the middle fossa. Just a quick case of extrinsic invasion of the facial nerve. This patient presented with a facial palsy, but has a meningioma. Notice all the bony sclerosis around the meningioma along the middle fossa. It's growing back into the geniculate region. In the temporal bone, you can see a little bit of tumors grown into the middle ear, both on the CAT scan and on the MR with contrast, tumor growing along the facial nerve, and you can see the intense sclerosis and hyperostosis that really clinches the diagnosis of meningioma in this case. Vestibular schwannomas may arise either from the superior or inferior vestibular divisions. They can be intracanalicular or present in the CP angle. They may be intralabyrinthine, although those are rare. And most grow very slowly. So I'm going to show you an example of that. This is a typical vestibular schwannoma on MR, which is pretty much filling the internal canal. It's kind of dark on T2. It's abutting but not displacing the brachium pontus. And you may see uniform enhancement on contrast scans, or there may be some heterogeneity. This is a case of a patient who presented with right facial numbness. Notice, even though this tumor is in the cerebellopontine angle and it does approach the fundus of the internal canal, that the tumor is not centered at the internal auditory canal. It's centered more anteriorly along the posterior slope of the petrous bone, and there's a thickening of the petrous apex underneath the tumor. It's relatively dark on T2. It's extending up and impinging on the cisternal part of the fifth nerve. So you've got a tumor that's not in the right place for a vestibular schwannoma. It's got hyperostosis. This is a meningioma. And the main differential for vestibular tumors at the CP angle near the fundus of the internal auditory canal is meningioma. This is an intracanalicular tumor. So there's no cisternal component on pre and post contrast MR. This is a case of small vestibular schwannoma that was only detected in retrospect on a follow-up scan because the initial study was done for a completely different reason. So I guess the message here is, even on scans for other reasons, if you're doing a contrast study, at least take a look at the internal auditory canal to see if there's an undetected and perhaps asymptomatic vestibular tumor. You may pick some of these up, and that's how I picked this one up on the old scan in retrospect once the patient finally did present with a tumor that had grown in the interim 4 years later. This is another, I think, difficult case to pick up. This is a patient who had a vestibular schwannoma that was cystic and looked abnormal if you're looking. This canal is too wide and there's a mass in the CP angle, but this was missed in this patient who was being worked up for a brain abscess. Years later, it was picked up because the patient had then clearly developed sensorineural hearing loss, which was not clearly present on the initial study, and there was a solid component and a cystic component, and it had grown. But you got to be vigilant in picking things up if you're not primarily doing a scan for that purpose. Cochlear schwannomas may be small. Here's an enhancing cochlear schwannoma. You can barely make it out on the T2 weighted image. Probably you would have missed it here. It's iso-intense to the fluid in the cochlea. Cochlear schwannomas are myelated by Schwann cells beginning in the medialis, just proximal to the spiral ganglia. So intracochlear schwannomas may arise in the region of the medialis. In the vestibular division of the eighth nerve, the vestibular fibers are unmyelinated lateral to Scarpa's ganglion. Therefore, schwannomas arising primarily within the labyrinth are usually cochlear origin, not vestibular origin. This is a case that I took from the neurosurgical literature just to illustrate a point. This was a 48-year-old woman who presented 12 years prior to the diagnosis with tinnitus and hearing loss, followed 6 years later by vertigo and disequilibrium, and followed ultimately years later with hemifacial spasm. And this is a neurosurgical paper that I think it points out how the radiologists who read the studies initially, and probably the neurosurgeons were looking at them too, missed the diagnosis until very late. And if you look carefully, there's enhancement of the cochlea on the early scans that were reported as negative, according to the article. Later on, this was also missed when the tumor has grown from the cochlea into the fundus of the internal canal and a little bit into the vestibule. And finally, when they made the diagnosis, here's a large tumor that's grown into the CP angle cistern. Part 3, the P plane. We have a tumor lower down at the level of the promontory of the cochlea that's approaching the V plane. This is the jugular foramen. And the tumor is confined to the middle ear. At this level, you would think of a paraganglioma, although there's a differential for middle ear tumors. If it enhanced and if the patient had pulsatile tinnitus, you could probably clinch the diagnosis just based on the non-contrast CT. Glomus tympanicum tumors, and this was one, arise along the tympanic branch of the ninth cranial nerve, or Jacobs's nerve, inside the middle ear. Glomus jugulare tumors, which may have components that look like that CT scan of masses extending into the middle ear, primarily arise around the jugular foramen, and they arise from the vagus nerve, or Arnold's nerve, in the jugular fossa. And again, they present with pulsatile tinnitus, conductive hearing loss, and visible masses in the tympanic cavity. Paragangliomas are often homogeneous soft tissue masses and enhance intensely, although they may have a speckled pattern on MR, because you see, in addition to the enhancing tumor, the high flow inside the tumor, or flow voids. So the vascularity of the tumor may cause signal loss on MR, and of course, you don't have that phenomenon on CT. Angiography, if you inject the external carotid artery particularly, its ascending pharyngeal and occipital and posterior auricular branches often supply these tumors, and you can do selective embolization preoperatively of these branches if you're thinking of operating on them. Also, these tumors, the jugular tumors, grow into dural venous sinuses, and you may see direct shunting of blood from the tumor into the venous sinuses. Just an example of a very large jugular tympanic tumor that's eroded the jugular foramen and has grown secondarily into the hypotympanum. So once you see that there's tumor that's in the jugular foramen, it's no longer a jugular tympanicum, it's a jugular tumor that's secondarily invaded the tympanic cavity. But this is still all you may see. And if the patient presents with pulsatile tinnitus and the ENT looks through the TM, all that he or she may see is a jugular, is a vascular mass in this location, and the imaging is critical to define the extent of the tumor. This is a jugular tympanic tumor that is involving the jugular foramen and the tympanic cavity. And selective angiography, this is the lateral view of a occipital artery. Occipital artery is a branch of the external carotid, and the stylomastoid branch of the occipital artery is supplying a part of this tumor. If we then remove our catheter and place it into the external carotid more proximally and place it into the ascending pharyngeal artery, we can see that there's tumor supplied by it. So these tumors are supplied by multiple small branches of the external carotid. So-called tip of the iceberg again. So here's an axial CT scan, and the first thing that may catch your eye is that there's a soft tissue mass in the posterior hypotympanum invading bone. But if you're paying attention, you can see the gross erosion and moth-eaten appearance of the petrous pyramid behind the carotid artery canal. Again, this is a VV plane feature, the carotid artery and the jugular vein lower down. But one of the problems with glomus tumors, even though they're typically benign, is that they invade the eversion system of bone and become quite extensive into areas that are very difficult or impossible to do a complete resection from. And that's particularly true once the tumor invades the bone around the internal carotid artery. And here on the coronal plane, we can see the same tumor. It's invaded the petrous bone more medially. It's undercut the round window niche in the inner ear, and the internal canal. So these become problems, not because they're inherently malignant histologically, but because they're malignant by location. And this is the typical MR pattern of a paraganglioma. Notice that this tumor is encircling the flow void of the internal carotid artery at the level of the jugular foramen and the hypotympanum. And even though this is a contrast scan, there's a lack of complete uniform enhancement because of these flow voids and the salt and pepper pattern that is so typical of a jugular paraganglioma. And on the sagittal T1MR, you can see that the tumor in the jugular vein has grown down into the top of the jugular vein. So the vein is occluded, but it's still patent down below, because the blood flow circulating in the tumor exits the tumor inside the jugular vein. All right, differential diagnosis at the hypotympanum. I have a normal temporal bone on this side. Look at how the jugular at the carotid canal has a firm bony margin laterally, paralleling the aerated eustachian tube orifice, and the lateral extent of the carotid canal shall never be more medial than the basal turn of the cochlea, which you see here. On this side, look at the basal turn of the cochlea. The carotid artery is way lateral, doesn't have as thick a bony margin. So in this patient who presented with a red mass behind the tympanic membrane and pulsatile tinnitus, this is not a jugular tumor. There's no bone erosion, as you would expect to see in the jugular region. This is an ectopic carotid artery. And you see the same abnormal location of the carotid artery on the coronal view. So in the differential, there's a broad differential for pulsatile tinnitus. Ectopic carotid is one, paraganglioma is another. And you can see here on an angiographic view and a diagrammatic view of ectopic carotid artery. If you like, you can go back to the study. I think we're sort of running out of time to go into details about ectopic carotid. And finally, just a few pathologic images to demonstrate the VV plane. We've been talking about it all along. I think you've already seen images on the axial plane of the carotid canal and the jugular foramen, carotid canal, jugular foramen, basal turn of cochlea, relationship to carotid canal, a little bit higher up. Just a couple of points. Remember that the jugular foramen and the jugular vein is usually very asymmetric in size. So it's typical to see one jugular foramen much larger than the other without it necessarily being pathologic. This is a large jugular bulb. It's normal. There's no tumor here. The jugular plate is thinned. So looking into the middle ear, you may see a discoloration that may look like a vascular mass. So a large jugular bulb is in the differential of a blue or reddish mass seen by the clinician behind the tympanic membrane. Sometimes the jugular bulb may actually be dehiscent and bulge into the hypotympanum. Protrusion of a portion of the jugular bulb may occur in about 7% of the population, and patients may have all sorts of symptoms that may or may not be related. So if you do a vascular imaging study, you'll be able to distinguish a normal bulging jugular vein from some other pathologic process or tumor. You just want to make sure that they don't go in and try to biopsy something of this sort, thinking it's a vascular tumor, because you may have a severe hemorrhage either from a vascular tumor or by biopsying the jugular bulb, which you never want to do. All right, finally, whenever a patient has ear pain, don't forget that there are other things around the temporal bone that may cause pain. Always look at the TMJ. This patient had rheumatoid arthritis. Look at the shoulder and look at the gross erosion of the condyle of the mandible. So I always include in my report on CT of the temporal bone that I've looked at the temporal mandibular joint and made sure that things that are being mistaken for temporal bone disease aren't really TMJ disease.